Okay, so welcome to October 11th Cancer Patient Lab meeting with Michael Hensley from BostonGene. We have two disclaimers. Number one, the information and opinions expressed during this meeting are not intended as healthcare recommendations or medical advice by Cancer Patient Lab, its principals, presenters, participants, or representatives for any medical treatment, product, or course of action. You should always contact your doctor about specific situations before pursuing any healthcare program, treatment, product, or course of action that might affect your health. And then secondly, this meeting is being recorded and will be available on our Circle site, both as video recording and transcript. And if you truly want to be anonymous, turn off your camera, change your Zoom name, and I guess stay silent. So now that that's done, just a little intro. As advanced cancer patients, we always want to have the best data about our disease as possible to help inform treatment decisions. And BostonGene provides AI-based molecular and immune profiling. Their tests uncover unique features of our tumor, enabling doctors to design the best treatment for our cancers. In a recent discussion we had with Dr. Subudi from MD Anderson, Dr. Subudi described how he used BostonGene as a leading provider of immune profiling. And he's the one who kind of got us in touch with BostonGene. Today, our speaker is Michael Hensley, Senior Strategic Account Manager at BostonGene, 16 years of diversified, comprehensive pharmaceutical, cancer diagnostic, medical experience. And he'll be presenting a BostonGene report and explain how patients can get access to their services. And I do want to thank Michael and also Dr. Subudi for helping me, and also Brian McCluskey get some testing. We do have to find out what's happened with my samples, but we also have a meeting coming up with, I forget who it is, on November 1, someone from your company, kind of an inside look at what is going on, how it's being done.
Yes, correct. So Kate's going to be presenting kind of all the BostonGene capabilities outside of our commercial tumor portrait test.
Right.
Yes, sir.
Okay.
Can you see my slides okay?
Yeah. Can we make that into full screen?
I'm not sure how to do that.
Try the slideshow.
It's in presenter mode, maybe, Michael. Please change the slideshow.
I apologize, everyone.
Menu at the top in the middle.
Oh, right where it says slideshow, up near the top. There you go.
Oh, so you're seeing my speaker view?
Now, there we go.
There you go.
That looks good. Thank you.
Okay, sorry about that, guys. World of virtual meetings. First of all, thank you all so much for having me today. This has been very exciting adventure, starting to work with you guys at Cancer Patient Lab. I'll lead with this. I never forget when BostonGene was recruiting me. I just celebrated my year anniversary, and one of my great mentors, he's the chair of breast oncology at MD Anderson. He was telling me, about this industry, next-gen sequencing or comprehensive genomic profiling, whatever you want to call it, is advancing so rapidly. It's kind of like computers were in the 90s. By the time you bought your computer and got home, it was already out of date. There was already faster RAM, better video cards, and so forth. And that's how this industry is progressing. And I came to BostonGene because I truly believe that we are leading that revolution. And so when you think about it, everybody does sequencing to a certain aspect. The question is, what can you do with the sequencing besides just providing biomarker targets with therapies, or biomarker targets that have a matched prognosis? And so at BostonGene, we do all that and more. So now we have 4 different tests. So today I'm going to focus on our tissue tumor portrait test because it is our most comprehensive. We do whole exome sequencing, so we look at all of 21,000 genes in the DNA. We do whole transcriptome, so we're looking at all of the RNA. There's no limited panels here or anything, so if you know, in a lot of our research collaborations, if we want to go back and mine all the sarcoma patients at MD Anderson for an emerging biomarker, we can do that because it was in our sequencing. But we also do, the biggest thing at BostonGene, I think is most exciting for prostate cancers, is we use our RNA sequencing through a deconvolution tool that we've named Cassandra to portray the tumor microenvironment. So if you think about, everybody investigates that tumor biopsy or that metastatic lesion as like, you know, the seed, but we go and investigate all of the normal tissue surrounding that. And what we do is we show what the tumor microenvironment is composed of and whether it's immune hot or immune cold. But we also do companion IHCs. In our report, we mine it through a biomarker database that's based on that primary diagnosis. So all the reports will be different based on the patient's primary diagnosis. We also have a formal collaboration with the NCCN guidelines. So when we do a BostonGene tumor portrait, along with getting the tumor tissue, and we also get a patient's normal DNA through saliva or blood, we also get the patient's progress notes, and we build out our report based on the patient's clinical history. So treatments they've been on, response, progression, so forth. And then we provide that in the report, but we also have an algorithm we've built with the NCCN guidelines, and we run that through an algorithm, and we present the next preferred therapies for that patient based on the NCCN decision tree. For community oncologists, this is huge because they're all the NCCN guidelines are changing so rapidly. It used to change once every 2 years. Now they change, you know, every 3 to 6 months. We also have a cup test. So in patients where there's a cancer of unknown primary, we use DNA and RNA sequencing to make a primary diagnosis call. It's a very exciting test. We just got our Captain CLIA certification, and we actually attached that to the BostonGene tumor portrait. For our liquid biopsy test, we are going to be launching this in early 2024. This will be launched as a reflex from our tumor portrait. So in the case that all the tumor tissue that's available is exhausted, then we can reflex to liquid biopsy, which provides great results, but much more limited than tissue. So the BostonGene tumor portrait, we kind of hit on some of this, but we do whole exome sequencing, we do tumor mutational burden, MSI, we look for key tumor alterations, as well as when we get the normal DNA sample, we also look for germline mutations, and we'll report that. But we also use the normal DNA to compare to the tumor DNA. If you don't do this, you can get a lot of noise. But when you sequence the normal DNA and match it against the tumor DNA, it greatly enhances your accuracy. And so it really helps, and it allows us to provide a more accurate result. As well as RNA sequencing. RNA sequencing is very exciting. There's a lot of fusions that are of high interest. But we also use RNA sequencing, so we'll have like PD-L1 and other biomarkers, and the concordance between PD-L1 testing, MSI, tumor mutational burden via IHC and RNA sequencing, the concordance is very high, but there's quite a few cases because of the variability in IHC reads that we've actually shown something like a PD-L1 high, and then they went back and ran the PD-L1 IHC and found it to be different than the original one. So, you know, it's kind of quantitative through RNA sequencing versus, you know, observer variability in, you know, a pathology lab. And then finally, the tumor microenvironment profiling. So we put this in our report, and the way that it works is we have an algorithm built through our RNA sequencing, and we have 29 molecular functional signatures that look at different elements of the tumor microenvironment. And based on how they're represented, we will have a call of one of 4 profiles. So on the one side, you have this immune-enriched tumor microenvironment. So this has a lot of really exciting immune cells that can be targeted with immunotherapy, immune checkpoint inhibitors. These patients, 1, have a better prognosis, but 2, have a much greater chance and sensitivity to respond to immunotherapy because there's a lot of exciting immune cells to turn on. And maybe even more important is we can identify this immune suppressed tumor microenvironment. So we call it a desert or fibrotic. And these patients have a very cold tumor microenvironment. It probably has a greater chance response to chemotherapy, but it's really interesting to see this, because what you'll see through all of these is you'll see high tumor mutational burden in these fibrotic or deserts. You can also see high tumor mutational burden in immune enriched, but you see a variability of the classical biomarkers that we use present day to determine whether a patient's going to get immunotherapy or not, which is mainly MSI, tumor mutational burden, or PD-L1. And so we are prognostic in 34 different solid tumor types right now. But the first paper in Cancer Cell that was published, the first validation, was focused on lung cancer, melanoma, bladder, and gastric. And what we're able to show is that when you have this immune primed response that is immune enriched and tumor mutational burden high, these patients have an exceptional opportunity to have a durable benefit of immunotherapy in excess of 70 to 80% in some of the different cancers. On the other side of that is this suppressive tumor microenvironment. And if this is along with a low TMB, these patients can have less than a 7% chance of a durable response to immunotherapy. So the point is to look at all these factors together. You know, obviously, to get BostonGene tumor microenvironment profiling into the standard of whether or not you would go on immunotherapy like IPI or Nivo or Keytruda, it takes perspective validation. It takes a lot of money. It takes a lot of time. And this is one of the focuses of our research alliance with MD Anderson. So this is the report. I think it was I can't remember who was saying the report was hard to read. But this is the first page of the report now. This is the summary page. We've developed this because this has all of the key information that a physician would have to make a decision. This is a prostate report right here. I don't know if you can see it well. It's kind of small on my screen. On the left side, we have all the patient's information, the tissue that was tested, where pathology was, the tumor content. You can see the first glimpse of the treatment timeline. So we use that. It's a nice cliff notes for the physician, as well as others looking at where the patient's been as far as therapy and response versus progression. Now, one of the places where people get confused that's easy to fix is there's two different areas of therapy options, and they can be remarkably different. At the top, you see this patient has MSI high, TMB high, an ATM mutation, and then a PIK3CA mutation, as well as a germline mutation. So this is based on our sequencing. And if there is a targeted therapy, it would be to the right of it. And then if it's a prognostic biomarker, it would not have a targeted therapy. It would just have a blue or red, which you see the blue is superior response. The middle section is the first glimpse of the tumor microenvironment. This patient had immune-enriched non-fibrotic, which is the hottest. And then the second section can be completely different, because this is what I was talking about, our collaboration with the NCCN, where we're running the patient's clinical history through our algorithm that we built with the NCCN. And then, you know, and depending on if they have biomarkers, this can change, because if there was nothing significant in the sequencing, then this would be completely different. And so for this patient, you know, obviously with MSI high, TMB high, immune-enriched tumor microenvironment, this is the holy grail for prostate cancer, for a patient to really have a great opportunity for response to ADT plus Pembro. But as you go into the report, it gets much more granular. We go much more in detail to the biomarkers. We go much more in detail to the therapy selections. We'll put the cohort analysis, the progression-free survival, overall response rates. We prioritize them to level of evidence. So we can get really deep and granular into the results. But as far as how this all happens, when a physician orders BostonGene tumor portrait, it's ordered like any of the industry tests through a requisition form. We go and request that with the pathology report and the progress notes, and then have the patient do a saliva or blood sample for the normal DNA collection. We, at the same time, will request from pathology the tumor biopsy that the physician wants to order. Once we marry those in our lab, we will usually have results in 10 to 12 calendar days. So we operate very efficient. You know, obviously tissue is the elephant in the room, so to speak, because viable tissue is key. It's not so much the size of the tissue, but it's the actual tumor content is what we look for. But another thing that I thought that would be of interest to you guys based on the mission of Cancer Patient Lab is whenever we spend a lot of time doing research for clinical trial matching. So most of the industry tests, they will have an algorithm built that's connected to clinicaltrials.gov. And so, you know, you could be in Houston and get a clinical trial that's open in Sacramento. And obviously there are certain times when we would travel for a clinical trial. But what we do is we customize our clinical trial match to two things. One, based on the sequencing, based on the patient's clinical history, but also based on the institution. So if you go to MD Anderson, you're going to get, this is an example of MD Anderson, you're going to get all the MD Anderson trials, and we prioritize them to probably the ones that are the biggest bang for the buck, so to speak, for where you're at in your cancer journey. So with that being said, this is you know, a summary slide of basically everything that we do. The one thing I want to note is that we have a robust financial assistance program. So it's weighted two ways. It's not for just indigent population. It's weighted on obviously financial. You have to put your household income, your number of dependents. We don't require any supporting documentation for that. But the other side of it, which I think is really unique to us, because in my career, I've never had this, is it's all, there's situational factors. So at MD Anderson, I get a lot of patients with excessive medical bills, travel costs for medical care, but there's also like, you know, fixed income, retired, and so forth. And at MD Anderson, more than 90% of our patients get qualified at 100%, which that means that regardless of the insurance determination, you know, you might have had inferior testing, but MD Anderson wants BostonGene tumor portrait. You know, we will work through the claim and through the appeals process, but in the instance that they deny or partial pay, we don't pass on those costs to our patients. And so I think that's a great testament to BostonGene. The other thing that we can do is we can do multiple tests for patients, and we can, you know, before and after therapy or later on in their journey. And then we can add a tumor evolution report, which is really cool because it shows the changes in key biomarkers. It also shows changes in the tumor microenvironment composition and the profile. And this can be really interesting with how therapy changes things, you know, whether you make a cold tumor go hot or vice versa, and then how do you treat it after that therapy. So I know Kate's going to come on in, I think, a couple of weeks to present all the other things that we do. But, you know, the BostonGene tumor portrait test is really kind of a great example of how we're taking this industry to the next level. And, you know, I know y'all had Dr. Sabuti on a few weeks ago. He's a great mentor of mine. We're doing some incredibly exciting work with him and the prostate cancer team, which we're looking at this tumor microenvironment and the variability of classical factors like PD-L1, MSI, and so forth, and seeing these patients that respond or don't respond to immunotherapy. And it's going to be really interesting. I think it will be treatment changing for prostate cancer patients. So with that, that was the best I could do, Robert, doing BostonGene in 10 minutes. But, you know, I'm open for questions, discussion. You know, I have additional slides, but I hid those. So, but, you know, hopefully I can answer your questions, though.
Okay. You can stop sharing your screen. That way everyone can see each other. That would be good.
Yeah, perfect.
So there were a couple of questions in chat, and then any other questions, if we can go with, raise your hand, and that way we can do this nice and orderly. So there were two questions in chat. One was, how do doctors usually address information learned about the tumor microenvironment? Medication, radiation, where do you usually see docs going with that?
So that's a great question. I think that we're still pursuing the ability for that to make the call for immunotherapy or not. Obviously, right now in the labels of most of the immunotherapy agents, you're looking at TPS scores or CPS scores or PD-L1, looking at MSI, tumor mutational burden. We feel that we're highly confident that the tumor microenvironment profile is going to tell a much bigger story there. One, based on it's coming from RNA sequencing, which is highly accurate, which is compared to the variability of various IHC tests. But I think right now you still have physicians that will give patients immunotherapy because it is a standard of care and it is the greatest opportunity for durable benefit. But they go into that therapy with a much clearer picture on expectations, because in the world of science there's no absolutes. We never see a 0 or 100%. And so right now that's the big story that we're trying to push forward. Takes a lot of research to do that. There's a lot of different solid tumor types. Everyone is different in their responses or lack thereof of immunotherapy. So that's where we're at now. Now, as far as like medication or supplements, I've never heard of anything like that trying to change the tumor microenvironment. The most common thing that changes the tumor microenvironment is various chemotherapies or monoclonal antibodies. But again, that's still hypothetical and it's still not standard of care, because if we knew how to change a cold tumor microenvironment into a hot tumor microenvironment and then give the patient immunotherapy, that would be a total game changer. So it's very difficult, and but it is one of it's definitely BostonGene's highest area of interest, but with a lot of our collaborations as well, is to continue the pursuit of validating this.
Rick Stanton, you put a question in the chat. You want to just ask it yourself?
I'm trying to figure out which question I asked.
About Codex?
Yeah. Okay. Hey, Michael, thanks for your time today. Appreciate your presentation. To me, the excitement of BostonGene and the promise that you hold for our group, and hopefully Brian, is the combination of genomics, RNA-seq, and your Codex implementation. So without the Codex, you're just the same as other shops to me. I know how to do immune deconvolution. Other shops know it. We come up with our signatures. That's great. And that's fairly cutting edge, and that's wonderful. But I've been trying to push on, Gary Nolan's lab, or to get the Codex system that would hopefully provide insights that would be complementary and beyond RNA-seq and genomic interpretations. So last time we talked, I really tried to help facilitate Brian, who has tissue. We got our guy Brian. He's actually has 3 sets of tissues from 3 glimpses of his progression. And I had hoped that we could use BostonGene as our first access to the Codex high dimensional immunofluorescent analysis in that emerging world. And Brian, are you there? Can you hear us?
Well, Brian and I have talked about it, so I can start off, and I see Michelle is one of our BostonGene brilliant team. So thank you, Michelle, for coming. I might phone a friend in a second. The point of my presentation today was to present what we have commercially. This MXIF testing, the technology is extremely expensive. There is no reimbursement for it, so it's not available to all patients. And then also Kate is our wizard of this area of research. We're obviously pursuing this in a research setting with various institutions throughout the United States, because our MXIF platform is outstanding, and we've been able to pioneer some different breakthroughs in that area. But and right now what we do that through research collaborations. So either they're done through a investigator's funding or under a pharma agreement, or a cash pay agreement. But there's no reimbursement for it right now. It's very expensive, and so today I was presenting on what we have commercially available that's available to all patients. But if you come back for Kate's presentation, I guarantee she's going to blow you away. You'll be holding on to that seat. So we're able to identify different cells in the tumor, outside the tumor. We're able to look at all of them. And Michelle, I don't know if you had anything to add on that.
Could you also just a very brief, what is Codex for the rest of us, or most of the rest of us?
Yes, absolutely. And hi, it's nice to meet everyone. I'm Michelle Lanman at BostonGene. So Codex is a type of spatial imaging platform that BostonGene uses, and it's a very advanced version of what is typically used in clinic IHC. So it would be a replacement of IHC imaging, but it allows us to see exactly in the tumor and the tumor microenvironment where all of the different expression level data, where it actually is located. So we can specifically see if certain genes or certain biomarkers are invading the tumor, if they're outside of the tumor, and that can play an important role in understanding, if something is not actually invading the tumor, then we might not want to target it because it might not actually make any impact on the cancer cells themselves. So it just gives us a much deeper picture and a much deeper look at imaging. And BostonGene does offer this, but as Michael mentioned, it is extremely expensive. And really that's the main reason why we haven't been utilizing it more clinically. We can offer it, and I believe we can do it as a fee for service. So we can get that information for you. We've really been utilizing it as a research platform just because typically in institutional systems, most people don't want it yet. It's just a bit beyond what they're asking for. And so really that's the only reason, but we can definitely look at what we can offer to you, Rick, and see if there's a way that we can help your patients. So we can find out some more information for you and follow up with you on that.
Yeah, and Brian and I have discussed the opportunity to do his as well. We're still talking about it. But the other thing, it kind of looks like, if you ever look like Google Earth and you look at like a GPS and look at the night skies over like big cities that are all lit up versus, it looks like that, but it looks like a Christmas tree. And I think it really, at MD Anderson we customize in 2 different platforms. So we have an MXIF platform for bladder cancer. We have an MXIF platform for prostate cancer, looking at different important markers, because we can do 40 to 60 marks on a single slide versus cutting 25 slides to do different various single markers. So it is very exciting, and it's definitely one of our core pillars in our platform. But it's kind of like the market's got to get there, and it's got to move through research to show any clinical actionability, and that's what the big thing is for reimbursement. But Rick, I'll say that in my prior role, I was doing a limited DNA panel, and I used to always go out like, oh, NGS testing is a commodity. It's who can do it the fastest, because my old company, we could do it very fast. I do think there's a lot of talent in the depth and the ability to make your calls on DNA. I think that RNA is still an art form. And I think that, in some of our guys in the lab are the equivalent of Van Gogh. But the deal is everybody in the market are looking at the tumor, and they give you what that tumor's saying. I think the novel thing about BostonGene is being able to portray the tumor microenvironment. The other thing that we're able to do is, which is really exciting, is we can identify in that tumor tissue the main clone, and then we can also identify subclones. And subclones are kind of how the cancer is escaping or getting smarter. And we can, and then we can also look in to see what's driving the subclones, and maybe there's a new biomarker target. So it allows you to fight the war from various angles, as well as I think that, you know, at MD Anderson, for example, and this is probably mostly towards academic institutions, we are really escalating their clinical trial match, because if you think about, like, if you go to the breast department, they have like 125 clinical trials open. It's really hard to place patients unless your primary investigator is a great salesman, for lack of better words, and, you know, really advocating their trial. And so we've really helped MD Anderson escalate their clinical trial match. So that's, you know, another exciting part of BostonGene as well. But, you know, I do understand on face value to make a clinic decision, you know, you find the biomarkers that have the targets, and you treat the patients based on those targets. I think with BostonGene, we just keep on peeling back layers of the onion to decode the cancer. And I think that's where a lot of the value comes. But you're correct. A lot of this is thought-provoking. It's confidence building, but, you know, it takes a lot of time, money, and research to get it to be a standard of care. And, you know, that's what we're working on at BostonGene.
Would you, a couple of questions, and I'll be quiet after this. Thanks for this interruption. Very expensive. What does that mean? It was like $6,000 or $8,000 at out of Gary Nolan's lab for a 40-plex. They have a little 40-plex panel. And just to explain what this is to other folks on the call, it's like immunohistochemistry. You have a slice of your tumor, and then you stain it, or you wash over, and this will be my interpretation. Michelle, please correct me if I'm, you know, living in the past of 2 years ago or whatever, but this is where I was really pushing to try and get spatial for me and our you know, group. So you wash over antibodies with fluorescent tags, let's say red, and these antibodies will be specific to a certain checkpoint or an immune modulator, or even a cell surface marker that would be indicative of a certain cell type, such as CD4, CD8, you know, immune suppressive cells. So you wash it over, and it sticks from the antibodies, and you do it. Typically they were doing three plex, like, you know, 3 colors. And so you take an image and you get those 3 colors, and you go, okay, now I know where these genes or these proteins are expressed. And then I wash those off, and I do it again. And so what I'm hoping for is more insight to, we're all advanced patients, and, you know, there's a lot of clinical trials, that's true. But when I go see my oncologist, he goes, Rick, what do you want to do? He doesn't, you know, he may push out 7 options. And same with Raina McKay at UC San Diego. Well, Brian and I kind of, and I'm sure all of us will go, what are you comfortable with? You know, do you want to do chemo? Do you want to try this clinical trial? So we go to see our oncologist armed with our RNA-seq data, our genomic data, and we normalize, at least I've normalized to the Cancer Genome Atlas to say, okay, we have relative expression right now. I know I have high relative expression of B7H3. So I'm on a clinical trial of B7H3 right now, antibody drug conjugate. So this understanding directly led to my current therapy. I'm hopeful.
Can you see my screen? Yeah, so I was just showing an example so everybody
Yeah.
can see what you're talking about, Rick.
Yeah, that's wonderful, Michael.
I'm sorry, I was frantically trying to find something to show everybody
great.
image, and this is the marketing piece, but it gives you an idea of
Yeah.
what it looks like. And you're right, Rick. We have a lot of projects that are utilizing this, and it is incredibly informative. But again, everything about like obviously if you have the resources to do it, it's great. I think from the cost, it's a lot different when we're doing a 100-patient study versus a one-off. But Michelle, I don't know if you know the approximate cash pay.
I know, and I don't want to give wrong information, so I'd rather follow up and provide that to you. I have, if you'd like, I have a couple of slides that I could share, just a little bit more detail, similar to what Michael was showing, but just I don't know if you all can see my screen.
And this along with we have another exciting product that's a blood test that basically it's immunoprofiling, like immune fitness test that basically does what we do with the tissue from the tumor microenvironment and a bunch of other things. That's emerging product for us. But when Kate presents to everyone, she's going to present both of these different technologies in a few weeks.
Yeah. So this.
What is her background?
Huh?
What is her background?
Oh, Kate's, I think she has 2 PhDs. She's
in what?
She's one of our pathologists here. She leads our pathology team and is one of our program managers as well, project managers. But this gives you a better picture of our spatial imaging. So here you can see, like, just looking at some of the specific stains, like it highlights exactly where these individual biomarkers are located. And if I can click through these, so we can plot out just exactly where everything that we find lives in and around the tumor. So it just gives us a much better picture in terms of the plotting of these different biomarkers. And so, these are just some examples of some of the reports that we're able to provide. And here, like, this is why it's helpful to us. So we can look at what is inside of the tumor, out of the tumor, and comparing that to our tumor microenvironment. We can see the differences in terms of, how much are not actually activating in the tumor, and how that translate with our tumor microenvironment profile versus those that are more active in the tumor. So this is what we offer. But Rick, we will definitely let us find more information out for you and get back to you on that. I don't want to give you incorrect information. So
that's great. I sure appreciate you guys. Sorry about being exact.
Yeah, you're okay.
Time for other people to talk.
Amit, you want to?
Yeah. Thanks, Michael and Michelle, for a very educational session. I have some very basic questions to me. I haven't used BostonGene, but I've had liquid biopsy and tissue biopsy done through Guardant and Tempus and Strata. And I just see calibration issues between the reports that we get. Few dominant things, everybody reports the same, but stuff that is the next level, and I did, one of my last liquid biopsies, I did Tempus and Guardant at the same time, and I get a very different kind of report. So I want to understand, what are the calibration issues, why they exist, how do you trust what you are getting? Because different companies are giving you different things.
Well, I think first things first is difference between tissue and blood is it's a lot harder to find, circulating tumor cells or DNA fragments in the blood. So, a lot of times a negative test, you might have not found it. Obviously, sensitivity is getting much greater in liquid biopsy testing. And sometimes, obviously blood's a lot easier than a biopsy. So that could be the difference in those. From tissue test, one thing we do is one thing that BostonGene has not been great at is marketing, because our competitors are marketing gurus. They have 150 reps and we have 12 reps. We kind of did it backwards, where we developed all this validation and built up this body of scientific evidence. And now we're in a commercial launch. So a lot of people have never heard of BostonGene. So when we go to one of my tactics, for lack of, I'm sorry for that, but is I always say, what was a patient that you didn't find anything great, that you got Tempest testing, that, nothing was remarkable. What's a patient that keeps you up at night? Let me do that as a pilot. Let me do a test for free for you. And then, it's remarkable how many times we will find stuff that was missed. So you could, it depends on your depth of sequencing. A lot of these tests say that they are looking at everything, especially in the RNA side, but they're not. They have a limited RNA panel. And there's just a lot of different talents in the sequencing of doing this. It is very, very difficult to do this technology, and especially on a commercial level, because you have to, size for growing volume. But Michelle, I don't know if you or Rihanna, if you had anything to add to that. It's a common question because you do get, you're right, you do see the same big results, but then, you see differences in other things.
Yeah, I would say if you're asking, so your question was specific to why are there differences between two different liquid biopsy reports? Okay. Yeah, so in terms of that, there's a couple of different reasons for it. Number one is that all of the liquid biopsies that are on the market today, they're all designed a little differently, meaning they look at a lot of the same genes and biomarkers, but there are some differences. So each of them are different sizes. So you might get the same genes, one set of genes from one company and one from another. So just for example, like our liquid biopsy panel has about 216 genes. Guardant's FDA approved panel has 55. I think they have a 74 gene panel. Tempest is around 105. So all of them vary in terms of what they're looking at. So that's one of the differences. But also in terms of the technology itself, while all of the labs could use the same exact equipment, it's how they actually tailor that equipment and design it for their own sequencing purposes, in terms of setting up the probes, the depth of coverage, like how deep they're reading into the DNA information. That will determine on what can be reported and what cannot be reported. So there definitely is, there are differences amongst reports in the liquid biopsy. And that's one of the challenges with, it's a great product, but one of the challenges is that there is going to be differences between different tests, but also in liquid versus tissue. And so, I think, in terms of, I can't speak a lot to the other labs, but we have really validated our product to make sure that what we report is high sensitivity and high specificity. I think one of the concerns out there is there can be, so true negatives is something that is difficult. You cannot truly write off a biomarker finding if it is not found in liquid biopsy, because there is a chance that it may not have just been picked up. And then there's also a concern about false positives with liquid biopsies as well. And so for BostonGene, we have something that we built into our assay called chip filtration, which essentially helps us to filter out all of the noise. So there are a lot of mutations in the blood that look like they might be a somatic mutation, but they're not. And so we actually analyze white blood cells, which helps us determine which of those are true mutations and which ones are not. But for all of those reasons, and I know that was kind of a long-winded answer, there are differences amongst each assay because they're all designed a little differently. So I hope that gives you a better idea as to why you might see different results.
So how do you make decisions when you get different results, right? To give you a specific example, I did liquid biopsy with two companies at the same time. One reports an mTOR of 55% allele frequency. The other one reports mTOR not detected. Now, if as a clinician, how do you, or as a patient, where do you go with that data?
And you said that the blood draws were taken at the exact same time for those tests?
Pretty much. Well, not exact same time, same week, I would say.
Okay.
So hopefully, again, my body environment has stayed the same, but it wasn't exact same time.
Well, and so I asked because that is actually important. So circulating tumor DNA, it can change, and it does change over time. And so the timing of the blood draw can make a big difference in terms of the information that we are detecting. And so if you are having blood draws done at different points in time, we are definitely expecting to see that the results are going to vary. And that's part of why we're now using this to look at disease monitoring, because we know that if we see some mutations drop off, then that might show response to some treatments and so on. But so if you're not having them done at the exact same time, there will be differences. And, my best recommendation would be going back to your oncologist to determine what information is the best to act on, because while it reports a lot of good information, not all of it might be the most actionable, or it might not be the most relevant to you immediately. And so that would be something that would be a decision, for your oncologist to have, and potentially to follow back up with the liquid biopsy company for them to explain a bit more as well.
I love David's quote in the chat.
Yes.
Dr. Sabuti warned me about you guys, so I had to phone a friend and have Michelle in, because he told me you guys were at the top of IQs for.
These are great questions.
Yeah.
All right, thank you.
Someone put in chat, and I think, so are you, especially since you're doing a lot with MD Anderson, are you looking at the outcomes that are happening based on your, reports and the treatment that's occurring, and kind of creating that feedback loop?
Yeah, I think that's one of the weaknesses in
Hopefully
most
that's the question
diagnostic
you were
labs.
asking, Richard.
What?
Sorry, Richard had put in the chat. Hopefully that's kind of the question you were asking.
I
Yeah,
think it's
100%.
exactly the question. Yeah.
Okay, good.
Yeah, because a lot of the weaknesses with these companies is, you have these archived tissue banks, and you can go and mine like 200 prostate cancer patients and find, biomarkers, but many of these patients are lost to follow-up, whatnot. And so one of our big collaborations with MD Anderson, it's called the Bigger Study. And so what we do is when, and we do this in various levels. Some of them are under very formal IRB arrangements. Some of them are more like when we find a unique report, we make a case out of it. And then our research team will reach out to the ordering, if they agree to let us follow the patient, we'll reach out to them every 3 to 6 months to understand the patient, how they're doing on current therapy, whatnot. Some of these patients will test multiple times, and as they go through their journey. But yes, I think the biggest thing, especially with our tumor microenvironment profiling, is following these patients not only short term to see like some of these studies are seeing these huge PSA drops in these immune enriched tumor microenvironments, right? Well, that's great for a time, but how does that look 6 months down the road? Now, we just started our commercial test in 2021, so we're on this pursuit. But yes, so we are absolutely following patients for clinical outcomes in dozens of different cancer types, and some of them are very formal and as part of like a biopharma partnership. Some of them are more informal, finding a unique case in a cancer where it doesn't normally happen and whatnot, and then we follow them together, and then we write up case reports. Or, in the instance with Dr. Sabuti and Dr. Siddiqui, we're looking at all metastatic castrate-resistant prostate cancer patients, looking at, patients that all have high TMB and high MSI, but they have different tumor microenvironments. So you're taking a homogeneous population and it's heterogeneous now, and then they're treating with immunotherapy, and now we're following them to see outcomes. So yes, in multiple ways are we following patients. So Richard, I hope that answers your question.
Yeah, just to follow up on that, and maybe a quick follow up on Codex. So, this is obviously not like an iteration of an operating system where you throw out the next revision. So as you get this data, you can't just, I assume you can't just throw it into your report. An anecdotal report is now sort of built into the next version of your report, but it's really useful information, particularly for patients who probably, are very eager for anything that they can get that would be helpful. So do you have sort of a way to get the case reports? Can patients see the case reports? Doctors see the case reports? How do you integrate it into the report? What's your strategy for that?
So if there's a case report that we work with a physician on, then we will usually publish that together. I think one thing that BostonGene, which we talk about internally, is to develop, patient cases, outcomes for external, marketing purposes or just education purposes. We don't have an avenue right now for patients to look at that, besides one we've published in medical journals. But for the reports. So if there's a emerging biomarker that either is emerging or it has now is a companion diagnostic, it's put into our report. It's extremely fast. If there's, we have teams that look like an army of ants at all the different conferences, and we're constantly, and then when we come back, we mine everything from small studies to the pivotal phase 3 studies that are presented, that are on, up in the lectern on stage, and we adopt those into the report. In our report, we also prioritize information by level of evidence. So you'll see, some rare cancers, like for sarcomas, for example, sarcoma mirrors breast cancer a lot. So you'll see a lot of off-label therapies in sarcoma because they have great efficacy in breast cancer for a PIK3CA mutation. And then you work up the prioritization of therapy recommendations based on level of evidence, and then also clinical outcomes. So there's a variety of things we're going to, but just because we have an exciting little pilot with metastatic castration-resistant prostate cancer patients, that doesn't go into the report. This has to be published at a conference and validated and so forth. So those are exciting like case studies, but they don't get adopted into the report. The report is all it goes through a lot of clinical validation.
Can you give some idea of how many diagnostics you run a month, say?
Well, I'd say probably at MD Anderson alone, we're probably doing about, all tumor types, probably 300, 400 tests a month. Nationally, I'm just not sure. We are really good allies at many of the large academic centers because they get it and they like to go deep into the weeds with what we provide. But if you remember when I presented to you our new summary page, that was our solution for our community oncologists, because they don't have the time to go deep. They need to make clinical treatment decisions. And so everything's up on that front page. And so now we're getting an incredible amount of growth in the community. Also, as patients go like to MD Anderson, they go back to, San Diego with their report. Then the San Diego oncologist is calling me like, hey, what is this? I want this. So then I call Rihanna, and then, it's just this waterfall.
No, I know, I understand. But the reason I was asking is just, so maybe MD Anderson is a major partner, so maybe you're doing a few thousand a month. If you're starting to stratify the universe into a reasonable number of markers, you're very quickly going to be into very small numbers of markers. So, you're not going to have any kind of statistical significance, but nevertheless, you might have some useful data. But it's not a discussion to, get lost in the weeds about. I just was curious if there are ways to take that information and let patients get access to it, because I think some of it would be, at least anecdotally, very interesting to them.
Well, yeah. And then we also have
about, Michael, I was just going to say really quickly, we get in about 400 tests a month right now. 400 to 450 is what we're receiving at BostonGene overall out. So that is including MD Anderson, but that is across the nation. So I just wanted to share that. Sorry.
Well,
go ahead.
But also we have a huge biomarker database that we use. It's not based on only BostonGene samples tested. So Michelle, I don't know if you wanted to mention about that.
Yeah, so just to add on to what Michael was saying, so we have built a lot of our own internal databases. So we have a biomarker database, clinical trial database, treatment database, and so we have those built internally where they are constantly scouring the literature and information out there. So that way, any new FDA-approved therapies, any new biomarker discoveries, those are all fed into our databases. But we also have AI learning that is built into them as well. So just to what you were saying, Richard, is that as we continue to aggregate the data from the patients, we are building up those internal cohorts and our databases. And so as we are building those out, we are learning more information from the patients we're testing and then using that to make smarter decisions and help with the biomarker selection, the treatment selection, and so on. So we definitely do use that data. In terms of case reports, though, we haven't made those publicly available yet, but I know that we've discussed that with our marketing team. So we do want to be able to share that. I think we have a couple of patient stories on our website. But we do want to share more stories about how we've been able to help patients, what the findings were, how those were helpful. And so that is something that we want to do more of in the future. So that's great feedback. Thank you for sharing that.
Michael or Michelle, I have a question. So you talked about doing multiple testing and the tumor microenvironment. In doing testing over time, have you seen tumor microenvironment that in the primary tumor is very positive, and then when you test, say, in bone or somewhere else, that the tumor microenvironment has gone fibrotic, or what changes have you seen, or have you seen enough to make any determinations as to what happens with that over time?
Well, I think that the bone tumor microenvironment is always going to be different than soft tissue, and obviously the complexities of bone and being decalcified in non-acidic solution, being able to pull DNA and RNA. It's very difficult. But I think when you talk about the tumor microenvironment changing between treatments, so whether it's cytotoxic chemotherapy versus immunotherapy, I think that even like the experts like Subudi, there's still the jury's still out on this because it's mostly anecdotal, like case examples. But we do see it because we do our tumor evolution report a lot, and it really depends, and we see drastically different changes in key biomarkers as well as the tumor microenvironment. So, but I don't know how to answer the question of what can cause the hot to cold, cold to hot. I think there's no absolutes. So, but it is a high area of interest. And we actually have a project in renal cell cancer. I mean, not renal cell, sorry, bladder cancers, and then mesothelioma, because we're trying to understand that more. How can we, we want to turn it hot, right? And so how do we do that? And so, that's an area of research discussion.
We're right at 1:02, unless there are any further questions. If not, thank you, Michael and Rihanna and everyone else from BostonGene.
Yeah, thank you so much. I've enjoyed every minute of visiting with all you guys, and through this meeting and past meetings. I love the website because I've been looking through the forums and past presentations. I think what you are doing is remarkable. I am very excited that you are moving to other solid tumor types. I think that I've definitely celebrated y'all and y'all's mission within BostonGene, and I think we would love to collaborate further with you guys. So I'm thankful for the future opportunities as well.
Okay, great. All right, I'm going to stop the recording now, and thank you all.
Thank you, Michael.
Yeah, and somebody asked for my contact information. I didn't know if